Okay, so thank you everyone for joining us again. This is the fourth surgical conference of the academic year, and today we're going to have Dr. Neal Patel present for us. So let me just stop my share. I think that worked. And Neal, you can take over.
All right. Thank you, Dr. Deobhakta. Can everyone see my screen?
Yes.
Wonderful. So I'll be presenting a case that I did with Dr. Landa. This case was done in a 50-year-old woman who is presenting to us with 2 weeks of vision loss in the right eye. And so she's actually pretty well known to the retina service here prior to this presentation of vision loss. She has a medical history notable for HIV, and she initially presented to the retina service about 1.5 years prior with CMV retinitis in her left eye. At that time, she had a CD4 count of 32. She was treated with antiretroviral therapy for HIV, oral valganciclovir, and numerous intravitreal foscarnet injections. About 6 months after that, she developed CMV retinitis in the right eye, which is the eye that we're operating on in this presentation. And that was still 1 year prior to her surgery. Currently, she has been well treated for CMV retinitis, which has been quiescent for the past 6 months, and her CD4 count is recovered into the 300s. And on presentation here, visual acuity is decreased to 20/50 in the right eye from her baseline of 20/20. She's 20/25 in the left, pressures of 10 and 15, and otherwise unremarkable anterior segment. She's phakic. So here is her examination in this right eye, and she's found to have an inferior retinal detachment from about 4 to 9 o'clock with 2 circular breaks right here at 6 o'clock. There's some adjacent intraretinal hemorrhages, and the fluid does track into the macula. Superiorly and nasally over here is where her prior CMV retinitis was, and we see some pigmentary changes related to that. Here's an OCT through her fovea, which shows some subretinal fluid, as well as an ERM distorting the contour. And this lower image is the lowermost slice in the OCT, which demonstrates some more subretinal fluid as we go inferiorly. So before I tell you all about how we approach this case, I just wanted to informally poll the audience and see how would you approach this retinal detachment. And just to summarize, we have a 50-year-old phakic patient with a history of CMV retinitis and a shallow inferior MAC-off RD.
Yeah, so Vincent, I mean, I know I don't want to be calling on people, but what would you guys do in Canada? I mean, obviously, you know, it's probably yeah, but what do you think?
Oh, after they wait on our wait list and get a funnel. No, I usually take the cataract out at the same time, and because I'm planning to do oil, I would plan to do oil in these cases. We just had one recently like this, same kind of presentation, and yeah, because I feel like if you leave the lens in there and they get a cataract, you can't tell when they're getting the inferior PVR, and then you're deciding to take out the oil, and you're probably going to leave the oil forever anyway, so you might as well take out the lens at the same time.
Matt,
Vince, I would joke about it. I would say it's very fresh for Vincent. He needs to wait longer.
So Vincent, do you put an IOL in?
Yeah, I put an IOL in because it keeps the oil from coming to the front.
Okay.
Matt, what would you
Why not
do?
just do a primary buckle?
Yeah, I feel like I would want to do a buckle to avoid having to deal with the vitreous and causing all breaks everywhere and having to put oil in.
I'm just always not confident that all the breaks are the ones that I find on exam with these CMV patients, because when you go intraop and you put the Perfor on, all of a sudden fluid's pouring out of every little hole in the retina, I find.
Except in this case, it's away from the area of the initial CMV retinitis.
Yeah, that's a good point.
I'm sorry, I keep like interjecting. Well, I heard from Bree. I was going to ask Bree, did you say you'd just do a primary buckle?
Yeah, I would do a primary buckle. And even with those posterior breaks, you could put kind of an additional element on to support that. But especially with the inflammatory disease, I mean, I would do everything I could to avoid going inside the eye with an inferior RD. But I typically have younger patients and trauma patients, so I'm typically doing buckles. Yeah.
No, I mean,
Bree, what's your favorite buckles? Which one are you using? Like, did you change your since fellowship something, or are you still doing what?
No, the only thing I've added is I will add elements. I'm trying to think what specific elements. I just grab whatever's on the shelf. But no, I still do kind of 42, 72, and then I'll add elements for more posterior breaks.
Okay.
Is there anything adjuvant that you'd give them then? If you, let's say you did just a primary buckle, or would you just treat this straight up as a, you know, an RD, the way we treat a normal RD?
I would treat it as a normal RD and then probably give like hit harder with steroids afterwards, just to make sure there's no, you know, really limit the inflammation. But otherwise I wouldn't, unless there was something on exam that made me concerned, I wouldn't get too aggressive.
Yeah, I love these answers, because it just goes to show you that there's really multiple ways of approaching this. So what did you guys do, Neal?
Thanks. Yeah, and Dr. Powell actually agreed with us to some extent. We did decide to do a buckle with some additional buckle elements. We also did a vitrectomy and used silicone oil for a tamponade agent. So we did a buckle vit here. And I wanted to highlight some of the elements that we used here for the buckle, because one of them was very new to me. We used a 40 encircling band and a 70 sleeve, but we used this additional 276 element.
Sure wasn't a 240?
No, it wasn't a 240. We actually looked for a 240 and they didn't have any left. So we used a 40 and it still fit.
They don't have 240, unfortunately. Yeah, we're looking to 240 and they don't have it.
The 40, did it fit into the track?
It did, yeah.
Okay.
And so this 276 element it comes as a round circle. You cut it to the size that you want, and it has this groove that allows the encircling band to fit snugly right there, and that holds it in place. And this 276 element is designed asymmetrically, so that it has a longer lip on one side, and you can orient that posteriorly so that it supports the breaks a bit better. Something that was new to me. And so why don't we move on to the video? Right, so we start out with a pretty standard scleral buckle. We make our peritomy, and we dissect into the 4 quadrants. We hook our muscles. Here I am hooking the superior rectus. And we put a bandage contact lens on during this initial part to protect the cornea, knowing that we want to have a good view for the vitrectomy later. We use a belt loop style to secure the encircling band. So we make some radial incisions and connect them with a partial thickness scleral tunnel. We know that we want this buckle to be relatively posterior because those breaks that we saw earlier were on the more posterior side. So especially in these inferior quadrants, we try and make this as posterior as safely possible. And then we pass through our 40 band and secure it to the sleeve and tighten it to the globe. And at this point, this is where we place our additional 276 buckle element. And so we place this inferiorly in the area of the breaks, and you can see that longer half is oriented posteriorly. And now we can just watch me futz around, try to get this underneath the buckle for a little bit. But eventually it does snap into place underneath that encircling band, which holds it in pretty snugly.
Neal, can I just interject real quick?
Yeah, absolutely.
So just a question, because I know you were doing this with Dr. Landa, but because you're doing a vitrectomy, is this why you're not going to mark the breaks? Is that the idea?
Yeah, I think so. Just because we know we're going into the eye, and I think we have a good thought that this buckle element should ideally cover that area well. And then we saw it snap into place there, and it did fit pretty snugly, even though the encircling band was a little thinner than the usual 240 band.
I just, Neal, sorry to interrupt. I just want to address some niche questions. So in this case, when we for sure our plan to do buckle width, in this case, you try to put the buckle as posterior as you can to support those breaks, because those breaks are relatively more posterior. So we don't mark them, but we do want to make them posterior as we can. In that case, we still want good support. And the reason I just want to discuss the vitrectomy, so even if she had, and Matt, he made a good point, so the detachment actually away from the area of the severe retinitis that she had before, but in this case, I feel like she, after this kind of surgery, she develops inflammation, and it's nice to have vitreous vitrectomy and not to have vitreous in the eye, because I do think it will help with less inflammation after the surgery and better recovery. And also during this surgery, we can a little bit to add more laser into that area. So that's why I think to do vitrectomy in this case, it will be more pluses and minuses. But again, there is a good point what Bree said about, to stay away, not to deal with the intraocular surgeries in those patients. But it's for me, it's not like clear yes or no. There's advantages, disadvantages, but we went with a buccal and vitrectomy together.
And how did you oh, sorry, go ahead, Dr. Rosen.
No, I was just going to say, so what did you do? Why did you decide to put a buccal on if you knew you were going to do a vitrectomy, you're going to put oil in? I mean, these cases typically don't have a lot of traction. And so, very often we manage them with just straight, if you already decided you're going to make a vitrectomy, I can see the argument if you're just going to do a buccal. But the question is, why did you think you needed the buccal plus the vitrectomy?
I feel like that she needed better support. I don't think that the vitrectomy will be enough, even with the oil. And I feel like, we want to do one surgery and that's it, and not to do reop surgeries in this case. And again, her retina is not completely naive retina. She has some area up above. I do think the buccal will support in case the area of previous severe retinitis so will develop some atrophic thinning or holes. I think buccal will be protective in those cases as well. If you would be, let's say, the same case without any history of severe retinitis, probably we wouldn't do vitrectomy in that case. We just would be the buccal, whatever Bree was saying. But I felt like in this case, it's not straightforward case, and we needed extra surgery. So I think buccal width will be more secure for her for the long term to make sure that she'll recover well. This was the thought.
Okay.
And adding the extra element before even seeing where the breaks fall on your buccal. How did you know to think to do that, or that you?
Yes, man. So in this case, the breaks are pretty posterior, and I didn't feel like our buccal, very thin, the 40 buccal will be enough to hold those breaks. And it's if it would be again without vitrectomy, probably would mark the break and try to put the buccal even without the element to try to make sure it's onto the holes. But in this case, I think the good support is important. Again, her retina is not normal retina, and with those patients you can see all the surprises later on when they develop in future, and the retina can be thin and severe retinitis can recur. So in this case, I want to make sure that she has a good support for long term. She's pretty young.
Thanks, Dr. Landa. And I'll also add, we weren't the most confident that she would be compliant with post-op positioning, especially with this inferior break. I think that the extra support of a buccal helped with that as well.
Go ahead.
All right, so we get that buccal element into place and move on to the vitrectomy. So here we're doing our core vitrectomy, and we see those two breaks inferiorly. And superiorly, we see the pigmentary changes from the prior retinitis. We stain the highlight with Kenalog and see that it's still down, so we start to elevate that. It's relatively adherent over the break here, inferiorly. And even more so, it was pretty tightly adherent over this area of prior severe retinitis. And knowing that this retina in this area is atrophic and thin, rather than trying hard to lift the hyaloid and risk creating an additional break, we decide to shave it down pretty close in that area instead. Here we're doing a depressed shave where unfortunately I do catch some of the retina and create an iatrogenic break.
So that's why you put the buckle on, you know?
Exactly. And we finish out the depressed shave, put down PFO to flatten. And really the shedding was really only coming from the 2 breaks that we saw there and nowhere else.
Can I just throw something in here? So I guess the question here, why you showed, and this happens to all of us, you had an iatrogenic break because there was a lot of motion of that retina. Why not put the PFO in sooner? And that's a question, I guess, to everybody. That's what I typically advise sometimes, to put the PFO in just a little bit sooner, because you've stripped the hyaloid up further than sort of where that bubble is. Because that provides this posterior stability that allows you then to not have kind of a bullous retina coming into your space. Sometimes you're just doing it because you're in a rhythm, but did you give thought to that or not?
No, that's a great point. I think that would have saved a lot here, and I wish we would have done that. So good to know moving forward.
Yeah, sometimes it's just when you're going through it, it's when you're pulling up the hyaloid, it's sort of like the next step is just to keep shaving and moving back. And sometimes it's helpful to just put that down. But okay, very good. Go on.
I agree with that. It's like you said, as long as you're in a groove and you just keep going. But another benefit is that if you've got your core vitrectomy and you've gone through the posterior hyaloid, it'll elevate the hyaloid up. So it'll sort of collect in this corner between the PFO and the retina, and you can kind of find it that way. It's a nice, easy way to find where the vitreous is, because you'll see that you shift how the PFO it'll warp the PFO a little bit, and the PFO will raise the hyaloid, and so you get this sort of added benefit of sending it right to the cutter. But also your buckle looks high enough that it didn't have enough of a depression to. You may have been over depressing a little bit. You were depressing on top of the buckle.
Good point.
Look, I just want to get from my experience, unfortunately, it's a good point to put PFC, but unfortunately, during my years of training fellows, it can happen either way. Again, especially every time I tell fellows that, especially in these young eyes, sometimes you try to make sure that the highlight is up and you tend to be more aggressive in terms of you pull too much and you want to make sure that everything is up, but sometimes you need to be less aggressive. It's not that Neal did a great job here, but you need to remember that younger patients, the vitreous is very sticky. It's come to you, you need to be more careful when you do it. And sometimes even you take all the precautions, but it happens, as Avnish said, it happened to everybody that you take a bite of the retina, and unfortunately it happens. So, but again, my message here is not to be very aggressive, and if you cannot lift it up, sometimes we have buckle in this case. I'm just hypothetically, let's say we really cannot lift up all the hyaloid, we have buckle here to protect the peripheral retina, and we'll do laser, so it will be okay, instead of trying to lift it up and to be very close to the retina and to make more heterogenic balls.
Yeah, and that's especially true in these inflammatory type of situations. You have a patient that's young with inflammation. So yeah, no, Neal, I mean, we're not being critical. It was just one of those thoughts that you can throw in there. But yeah, I completely agree with what's been said.
Yeah, thank you.
Yeah, and again, it's Neal was very, very careful here, but this is like for the fellows who are on call, even if you do very slowly and you very well trained, experienced surgeon can happen to you. So you need to be extra careful and not to be aggressive. It takes more time, unfortunately, in those cases. So you need to be patient, and it can happen. So the patience here is the secret.
Well, so one other advantage to what Avnish was saying in terms of putting in the PFO is if it should bleed, and if the retina is up and posteriorly. In this case, it wasn't, but the PFO is going to block the blood from getting under the macula. So, I mean, because these things do happen.
100%, Dr. Rosen, happened before.
Yes.
All right, thank you, everyone. Very good points. And so moving on here, here I am diathermizing the brakes. We move forward with the fluid air exchange. Drain from my convenient posterior retinotomy. And we're examining the brakes here, and we see that this more temporal brake is sitting right on the edge of that additional buccal element. And so we see if we can shift that over slightly. And I'm going to pause here for a second and just have everyone take a look at the anterior chamber here and see that it looks relatively normal. But then here, as we tug on that inferior rectus to superduct the eye, and we release it, we see an air bubble in the anterior chamber. And so we actually didn't realize this at the time, but we will realize this later. And what you can see is also that the infusion here is relatively flat and almost pointed a little bit anteriorly. And so what I assume must have happened is she likely had some amount of zonulopathy, perhaps from her numerous Foscarna injections, and it allowed some of the air in the posterior segment to travel into the anterior segment, possibly tugging on the muscle really pressurized the eye and pushed that anteriorly. And also I think the direction of this infusion probe contributed to that. But this is my first time seeing that. Anyone else in the audience have any thoughts of, or, have seen this before?
We certainly see that it happens on a regular basis when you depress after you have the eye full of air, because a lot of times the zonule is not complete. It doesn't even have to be somebody who's had injections. Another thought is, if you're right at the edge of the buccal, where the buccal is, sometimes, if you can go a little bit higher, just increase the, pull up the buccal slightly, that will catch it on the posterior edge of the elevation without having to move the element. So, but I mean, you have to balance that between not squeezing the eye and making it into an hourglass. But you definitely will, as the buccal height increases, you will gather up more of the retina. So you'll pick up that posterior edge.
Mm-hmm. Mm-hmm. Good point. Yeah. So here I am just kind of trying to put the infusion back in. Again, we didn't realize that the air bubble was in the AC at the time, and we do try and shift that buccal element a little bit more temporarily to cover that break. But that is a good point to increase the height of the buccal as well, which we also tighten a bit more as well. We're able to shift it a little temporarily, but it is eventually abutting directly where we made our belt loop, so we can't shift it too much further. And we do tighten the height of the buccal additionally as well. And so now it looks like both brakes are sitting well on the buccal and well supported. But we see the view is a little bit more challenging now with that air bubble in the anterior chamber. And so we move forward with lasering. And as we're lasering
the air bubble out.
Well, we haven't yet at that point, because we didn't actually even notice that it was there yet, honestly. And so while we're lasering, we see that the view is just getting more and more difficult. And that's when we go to inspect the anterior segment. I thought the cornea was just drying out or something, but we look, and here's when we realize, oh, wow, there's an air bubble in the anterior chamber. And we even see a little bit of feathering of the anterior lens related to that too, which I think was progressively getting a bit worse and making the view more challenging. We think about taking it out now, but we decide to hold off just yet. And try and finish
Neal,
out the laser.
I just want to have, sometimes when you have this bubble, it makes your vision even better, because especially if you do longer surgeries, it somehow improve your vision. So it happened to me when you have this perfect bubbles that fill in the whole anterior chamber. Actually, in this case, you need to do a fluid exchange or something. It makes better view, but not in this case. And again, in the beginning, it was not a bad view to the laser, right, Neal? And then it's got worse.
Yeah, I think it did progressively get worse. I think that was the feathering of the lens. That's what made it worse. But until that happened, it wasn't too bad.
Yes.
You know, Dr. Landa, I've had similar, oh, go ahead.
Go ahead. Go ahead.
I've had similar experience. Sometimes an air bubble does help, but with an intact lens, I haven't noticed it that much because it'll push the lens iris diaphragm back and limit your view, especially to the far periphery. But in eyes where the lens is out, or you can keep the anterior chamber relatively flat, I agree. Sometimes makes for a better view.
Yeah. So I would make it even further, Garrett. Whatever you're saying. So sometimes you do like not a great view, especially with pseudophakic lenses, and then suddenly, oh, it's so clear now, and then you go back and you see, you have the eye, like you do like refocus, and then you see, oh, there is a bubble in the AC. So sometimes it's helpful. It's prevent from fogging, But in this case, definitely, whatever Neal was saying, unfortunately, the anterior capsule of the lens was kind of pushed with the bubble, and it's make like difficult reflex to look.
So in these cases, I found that I'll just you can't just take the bubble out because it's basically going to just fill up again. I'll just fill up the anterior chamber with viscoat, and the view will come back. This happens in high myopes very frequently, and they're phakic, young phakic eyes. And I haven't had a real pressure problem with these post-operatively, amazingly. I mean, you have to obviously treat for the pressure, but if you have a great view, it's much easier to finish the case to your satisfaction.
So you leave the viscoat into your chamber at the end.
I would like to throw out here, like a couple of years ago, we have similar presentation, and one of the surgeons said that why don't you take lens out right now? Because it's eventually developed cataract and everything. Anybody would think like to take the lens out. Just I'm completely opposed to it, but I just asking somebody would any pros to remove the lens, to take the lens. Because
Vincent wanted to
because I remember we have this. I don't want to name of the retina surgeon who said it, but it was a hard discussion. I remember I was against it, but like we have to discuss it. Kind of why don't remove the lens, because it's inevitably develop cataract and it can So I don't know. I'm just throwing it there.
I mean, the thing is, Dr. Landa, like if you wouldn't take out the lens, and I know you do lens, TRD cases, I don't think many of us would in this case. This is like running to the goal line and just stopping and tying your shoe for no particular reason and not scoring. You're very close to finishing this case. And we all know that this person, if you didn't make a plan to do the cataract in the first place, I don't see why this would be the moment to do it. It doesn't feel like it's unstable. So the key here is to determine whether it's unstable. So if there's like zonular dehiscence and it's actually a phacodenesis thing going on, then perhaps you might consider it. But all of the things you just named were all going to be true when you put oil in the eye.
But let's say you see the lens is, we didn't see zonular before, and it's significant, and the lens is let's say this patient with a trauma, and before you don't see any phacodenesis, everything looks okay. You just go and you plan to do standard surgery, retina surgery, and then, you see the lens is like actually it's moving, tilted, iris diaphragm is very mobile, and you were not prepared to do the cataract surgery. By the way, I do think just a small remark. I think when you do phakic patients, we always need to do IL master before, just in case. But this is my point. So would you deal with the lens if you think, okay, the lens is not going to stay and the silicone oil will come forward? So I'm just throwing out there because we have this discussion, and I don't think you need to touch the lens. And as we all know, even if you poke the lens, and it happened to us, and literally the lens doesn't become white right away, you can still finish the surgery. And to do the cataract surgery or lensectomy like 2 weeks, 3 weeks, like 1 month later, it's not a big deal. Just I'm telling you as a discussion point here that I wouldn't do it. I don't know, maybe somebody will say, what, it's a good idea to take the lens out. I just want to hear what arguments.
Yeah.
Yes,
I mean, unless you're gonna do a PPL, you're gonna convert back to, you have to put fluid back in the eye so that you can do the cataract anteriorly, and you're gonna redetach the retina that you just flattened. Then you have to put PFO back in you kind of have to restart the whole surgery if you're gonna do it anteriorly, unless you're gonna do a PPL.
Yeah, and even PPL you can't do under air, right? Or it'd be pretty risky to do under air. I can remember I had one case with Dr. Barash, and I can think of only one reason to take out the lens at this point and do it the way Matt said. And that would be if the view was so bad, like the lens became opaque. And I had one case with Dr. Barash where we started with a lens that wasn't great. And we, just like you said, Dr. Landa, we did the biometry before because we were like, oh, we don't want to take out the lens to a 20-something-year-old guy. But during the surgery, it just became so bad, we couldn't see anything. We couldn't do the laser. So we did go back to fluid. And then we did phaco, like Matt said, from anterior, and then we had to restart the entire case basically. But that was just because we couldn't see anything, and that's the only reason I could think of to take the lens out.
So Vince, I think my message here, I think even the bad lens, whatever the lens you have, don't touch it. Just finish the surgery. As Nish was saying, we're very close to the end. And again, if you definitely cannot complete the surgery, you can do a fluid exchange, you don't know what we see, you don't know if the retina is detached, definitely need to improve your visibility if the only chance. But if the lens is a little bit tilted, if you think there is no lysis, just leave this lens, deal with this later. If you have a good view to complete the surgery, don't touch the lens. This is my point, because it will make this retina surgery much more complicated, especially if you're not prepared for it.
Yeah, definitely. Unless you have no view, I think there's no point in taking it.
Oh, Ike, are you on? Ike?
Yeah, I'm on. How you doing, guys?
Yeah, what's up, Dr. Ezon? Go ahead.
All right. So I'll add that, live to fight another day is a good concept there on not taking the lens. And in regards to completing the case, if it's just about putting laser, depending on where your pathology is in a given case, if you're putting in oil anyway, you can hopefully allow the retina to be attached under oil without the more permanent seal of laser. See if you have a view the next day or the next week in the office. And if you need to go back to the operating room and take the cataract out, that'll be a second plan. You take the cataract out while the patient's under oil, and then you'll put your laser in at that subsequent surgery. If you've gotten this far in the case, that's something else to consider. And in this case here, the instance where the gas moved forward was described specifically with a lot of aggressive pressure on the inferior zonules and the inferior portion of the globe. So you may be very well served. Take the air out now, fill some BSS in the anterior chamber, and it may suffice for the rest of your case.
Mm-hmm. Yeah, I agree with you, Ike. I mean, I think this doesn't seem like there's overt phacodenesis and like lens subluxation and all this kind of stuff. I will point out that if you do have like a sun-setting lens or some kind of completely just totally not secure kind of lens situation, the lens is literally, crystalline lens is going to the back into the posterior pole, you might want to consider then doing something, right? I mean, we can't, that's going to be a little bit more difficult. Yeah. You're already going to need to take the guy anyway. But in this case, I agree with everyone that this is live to fight another day. No cold third strike right now.
When you see this
I agree. Yes, just a sec. I agree with it was Ike who said I agree 100%. So even we had cases, actually, I would like to report it. We have cases, maybe 5 or 6 cases, and I already mentioned it before, when for some reason something happened to the lens, it was iatrogenic or other reasons, and we had to remove the lens when the eye was just regular PPV with the gas, and then we removed needed to do cataract surgery 9 days, 12 days after the PPV. And we removed the gas 12 days later, 9 days later, and we did the phaco, and all the patient did great, nobody redetached. So I think, and I discussed this with Amnish about his invention, I do think that sometimes you don't need gas for more than like 9 days. You know, we always want to have it for longer time, but those patients do well. So if you do need to deal with the cataract and is the gas in the eye, I'm not talking about the silicone oil, but Ike was right. I don't like to do cataract surgery when you have silicone oil filled eye, but we do, especially with patients with uveitis or patients that needed long-term tamponade. But you can take the gas out, you can do the cataract, and those patients, they do actually well. If you wait like 10 days, they'll do well. So nobody really touched. So it's a good point in terms of, again, I just opened this Pandora box about the lens in terms of to get teaching points that I don't think the lens should be touched unless you cannot complete the surgery.
Yeah, and it's a good point, Dr. Landa, because it's a tail risk event, like I like to say, but that's an iatrogenic one. You just start futzing around with the lens and then, you know, everything goes wrong with the retina. So it's a very good point to bring up. Go ahead, Neal.
Never
Oh,
mind.
Matt, go ahead, Matt. Oh, okay, Neal, go ahead, continue.
Yeah, so we thought we could make it to the finish line with this view. And so that's essentially what we did. We just finished the laser and we lasered the inferior breaks and also put a little bit of additional laser at the edge of the superior prior CMV retinitis in case that became a future problem down the line. And here's where now that we're pretty much done messing around with the posterior segment, we decide to remove this air, and we essentially just rinse it out with BSS until the bubble gets down to about, you know, that 10, at most 20% fill. And now we place our oil, and we see that the breaks are well lasered, and we top the eye off with oil.
What kind of
and
oil
close.
did you use, Neal?
5,000 Centistoke silicone oil.
I'm just going to throw it out there. I don't, maybe some of the private practice guys can mention it. Do you guys use anything other than, would you use anything other than that in this case? Like 1,000? Yep. I use 5,000 for virtually everything. So
I use basically what's available in the surgery center or the operating room.
got it. Okay.
It's kind of varies. If you expect it to be in for long term, you have access to either than a 5,000 for my practice also. But it's so much longer to get it out later.
True.
And we use our infusion as a chimney to get out any air that remains in the posterior segment. Rinse off to make sure there's no oil remaining, and close.
Neal, one more point here. Again, what Dr. Rosen mentioned, that in this case, it was the first attempt. Let's try to wash it with BSS. Again, we were lucky in this case, but usually as soon as the passage is on, like the gas will try to come forward. Luckily it didn't come, but the next stage will be to use what Dr. Rosen said, to use viscoelastic, like to try to push it. And, you know, because sometimes it's not that successful. So try to, let me ask the audience and Dr. Rosen, let's say if you try with viscoelastic and then you still see the fluid, the gas is coming forward. What next step, Dr. Rosen? What would you do?
So usually that's not, I mean, maybe your pressure's too high, but generally, the visco will hold. I don't, Healine may or may not, but the problem that I have with washing it out with BSS is you don't want it to go in posteriorly. It's because it may get under your oil. You know, and
we use it. Yeah, you're right, but it's a little bit so. But so in that case, if viscoelastic material doesn't work, you don't try to do Healon or Healon 5 something. You don't try this, right?
I've never had that happen. I have to say.
Okay.
I mean, probably my next case it will, but you know, generally, I mean, if your pressure is not excessive, the visco really holds it back. And it works really nice. You get a really good view, and it seems to go away without causing a lot of change to the anterior capsule. So, I mean, I've been lucky with that, but you know, I always worry about putting too much fluid in the anterior chamber for the fear that it may go back and, you it'll just lift up the retina a little bit.
I agree 100% with Wiscott, and again, even it's goes away like 3-4 days after from the anterior chamber, so you can leave it. It's not a big deal, and the pressure can be a little bit on high spike, but you can control it. And also our glaucoma colleagues, they do it all the time. They inject Wiscott and nothing happens, so it's not that dangerous to leave phakic patient with a Wiscott inside the eye. So definitely we would do it next step 100%.
The other thing that I'll point out, and this is something that sometimes when I'm with fellows or somebody, I'll get into not an argument, but like we'll suddenly discuss that the existence of air in the AC does not necessarily mean you have to make a PI. I didn't see you guys did, right, Neal? You didn't make a PI.
No, we didn't.
And just because there was air there did not mean that you have a unicameral eye. So I've had sometimes these conversations with fellows where they'll be like, well, I know they're phakic, but let's go ahead and try to mosey a vitrector in there and just start to cut up some things. And I'm like, don't do that. Like, figure out why the air came in the first place, and don't just assume unicamerality, so to speak. And this is an example of that. I hope, I don't know, maybe the oil is going to be forward when you show us the next image, but in general, it doesn't necessarily mean that.
Vanish, great point. I'm also like in this case, when you try to do PI in phakic patient and you're not very experienced, first of all, technically it's very difficult to do in phakic patient. You're going to those zonals already kind of compromised. You're going to make it even worse. And guess what? The air can come from the PI, and it happened to me. We do PI, and air comes very nicely through this hole that you just created. And it's a very good point. It's a bleeding, and it's kind of very aggressive. You have to do PI only if there is no chamber. You tried everything, and tomorrow it will be completely block whatever you need to do it. But in this case, I wouldn't do PI unless you're next to the wall, you don't have anything else to do, and you cannot complete the surgery. But it's a very good point that you brought up.
So wait, so the fear there is that you're going to get pupillary block even though there's a full lens? It's just never occurred to me to do a PI just because air gets into the AC.
It happens once in a while if you have a very loose zonule and the lens can move back and forth. I mean, I've certainly seen it, but it's pretty rare. And I agree with everybody that I wouldn't be aggressive. If you leave the eye relatively soft and everything is back, it's probably not going to be an issue. And you can have the patient face down anyway for the first 24 hours, and you see how it behaves. But
that's actually my worry when air is in the AC, that the oil is going to displace the air because it's more dense than the air. That's my biggest fear when air is in the AC, that the oil will find a way in because of the air there.
It's going to float up, right?
Yes, you cannot predict, Garrett. You're right. You never know.
That's my fear, is if you have a connection between the anterior and posterior chamber and you've got air in the AC, the air could find its way into the posterior chamber and displace silicone oil into the AC. That's always my biggest fear.
Yeah, if you have a full air bubble, you have a little tiny air bubble.
I'll give you my 2 cents, since I know nothing about retina. The air won't be a problem with pupils dilated. You'll go into pupillary block with a small pupil. By the time the pupil comes down, to keep the patient, if you can, with their head up, tell them not to lie on their back, and they'll be okay. I wouldn't do anything with the air. That's you're asking for trouble by trying to make PI or even to get the air out.
Or Dr. Silut, I didn't know that you hear. So if you hear, so in terms of viscoelastic, so
we're waiting for you to talk about it.
Whatever I said, it's true, right? You confirm that viscoelastic will go away in 3-4 days, correct?
Yeah, it will, but you can make the pressure pretty high with viscoelastic. Why not leave the air in? Air is a problem with a small pupil if the patient's lying flat. The air will go away pretty fast. And if you keep the patient's head up a little bit, there's generally be a little bit of space down below. The pupil's going to stay dilated for a little while. I think you'd be okay. I take my
Yeah, but
chances with
Dr.
that.
Sidoti, in this case, the visibility was also a problem. So, you don't, sometimes you don't have a choice. You need to displace it with viscoelastic. You need to keep it, because if you try to remove it after, the air will come again. It will be, it's
Oh,
not
if you're doing
good
it, if you
thing.
need to do it during the surgery, then use some viscoelastic.
Yeah, but again, is 3-4 days after, the viscoelastic should be out of the eye, right?
Yeah.
Yeah.
Okay. Okay.
Some glaucoma drops in anyway. I mean, and give some Diamox at the end of the case, and generally the pressure is not a problem. If it is, we call Dr. Sidoti.
That's right.
We have a full service retina conference here. We have glaucoma being consulted on the line. That's great.
And then Dr. Sidoti will ask why we didn't do PI during the surgery.
Yeah.
Well, no. I saw you. Now you marked the conjunctiva nicely, so I'm sure you're going to put it back. So when we go back to put the glaucoma implant on, we can have an easy time.
That's why we do it. Yep. Oh man, go ahead, Neil. Go.
Yeah, pretty much at the end here. So we give her a block at the end because she was under general, and there's our finished product. Hope Dr. Sidoti approves of the conj closure there. And that's pretty much it.
You notice he didn't say anything. I'm just like,
yeah, I know. Not the positive reinforcement I was hoping for.
Thanks to
Can I make-
layer closure.
Can I make one disclaimer about the contact lens? And Dr. Sidoti might want to cover his ears on this one, but we had not really. I used the contact lens once. I probably will never use it again because it fell out of the eye, and we've lost the contact lens, and we searched for it for the whole case. In fact, I was seeing parts of the orbit that I probably never thought I would see, looking for that contact lens, trying to find it around the buccal. I mean, I was sure it was not in the eye because of how much I searched. And then we eventually found that it had fallen off onto the floor. But you've never seen nursing staff panic like they did when we thought we lost the contact lens.
I hope you didn't put it back afterward.
Of course, no. Unfortunately, if you sprayed it with some BSS, it was fine. But, but that was a real risk, and it really traumatized our case because we had to look for it, and there was concern.
You get rid of it right in the beginning. I mean, after you put the buckle on and you put the suit. I usually suture, but after you've done that, I get rid of the contact lens. I don't. So I'm watching.
What happened? It happened while we were. I don't remember what stage of the buckle we were at, but we were putting the buckle around the eye at the time, and either securing the buckle or we were putting it through the belt loops. I can't remember. I can't remember when we lost it.
Yeah,
we just noticed once we had the buckle on, we noticed it wasn't there anymore.
Can you guys hear me?
Yeah, of course.
I had a side question. You mentioned over there that you gave the block at the end of the case. Does anybody prefer, even under general, to do it either earlier or in the middle of the case to prevent the pain from kind of signaling, even though the patient can't feel it because she's awake or he's awake? I mean, rather he or she's under anesthesia, but when they wake up, already that's been blunted.
Well, I like to give it oftentimes in the beginning if it's a deep set globe in the orbit, I'll give it in the beginning. But if it's it depends on how long the case is. I may give another block at the end, just infuse at the end so the patient doesn't feel anything. When they wake up from general, they definitely will feel it if you haven't done a block. But I agree, if you give it in the beginning, a lot of times it helps you because it will lift the globe up so that it's poking out of the orbit and it's a little bit easier. If you have one of these very deep set eyes, it can be problematic.
I give it at the beginning just because we can't discharge the patient until they're pretty awake. And so that, and if they have anything above a pain of 2 out of 10, the nurses won't let them leave. So I selfishly give it to them so that they can wake up. They don't have to, get as much as far as general, and they can wake up and go home and we can kind of get cases, because there's a limited number of beds in our surgical area. But and with that, like Dr. Rosen, I'll re-give it if it's a longer case and I feel like I need it a little bit more, but it helps with the post-op pain.
It doesn't take that long for it to take effect. So, I mean, if you're infusing it now, by the time the patient is, they pull the tube out, it's probably already done its thing. We give a mixture of lidocaine and, Marcaine. The lidocaine works real fast. The Marcaine is a little bit slower and lasts much longer. So, I haven't found an issue when I have done it at the end like that, but it's a good thought.
But I never had like patient complain from PECUs that they have so much pain, like if you do block at the end, until they recover, until they're ready to go home. I think it kicks in. So
But
it's not
Dr.
kind
Landa,
of.
the problem is the more special they are, the more they'll complain. So like, if
Okay.
a Navy SEAL, they will 100% be the kind of biggest babies you
I
ever.
understand. Okay, but
So that's why I give it at the beginning and the end.
I got it.
That's very frightening.
Well, we
to
recorded.
reveal that, because our national security is based on.
Yeah, I wouldn't be.
I mean, we're re-recorded, so I was gonna say, we love our
Don't
men
be too
and women in
impressed.
uniform. Okay, we love our men.
They
and
want
women.
to feel after the buckle. They want to feel like after the cataract, right? This is the goal.
Exactly. Well, and the other issue too is they will jump right into what I have issues with is how quickly can they start diving and jumping out of planes. And so that's kind of been a recurrent issue as far as, you've had eye surgery, please don't go jump out of a plane. Like things I never thought I'd have to say, I'm telling patients now.
Sure.
For post-op care.
We do that for our patients too. I'm just letting you know, Bree, but don't jump out of planes.
Don't jump out of planes. Please don't go dive.
Our 75-year-old, please don't jump out of planes. But that's great. Okay, go ahead, Neal.
All right. And so he shows up post-op week 1. I'll say post-op day 1, the anterior lens was clear by that point already, and she had a small air bubble in the eye. By post-op week 1, the air bubble was gone and she was doing well. There's no oil on the AC, visual acuity pinhole to 2100. We see our inferior breaks with some good laser and well supported by the buckle. And we have an OCT confirming that the retina was flat, both centrally and at least as far inferiorly as this OCT would go. She does still have this ERM with some distortion of the foveal contour, but all said, doing well. And that's all I have. Thank you to Dr. Landa and Dr. Aval for all their guidance with this case. And thanks to Dr. Deobhakta for organizing these rounds.
Yeah, that was a great case, Neal. I think there was a ton of discussion. I'm very appreciative to everybody that participated. Mike, are you able to mute your phone?
Yeah, no, sorry about that.
No problem. Yeah. So yeah, no, it was great. I just wanted to ask one last question, and then we're almost at the end of time. But when you guys sized your buckle element, did you use anything to size it in terms of the way you cut it, or you just was that a guess and test kind of thing?
It was a guess and test, but we should put a bit more thought into it. It conveniently actually spanned almost the entire length between where we made our belt loops, so it worked out well. But it would have been smart to really measure the distance between our belt loops and just get the most out of that buckle as we could have.
Perfect. All right. Well, thank you guys so much. I always want to get you guys before it, the bewitching hour. So it was a great session. We're going to have the next one after Retina Society, which is going to be in 2 weeks. So it'll be after that. Okay. All right, guys.
So no more cases, Avnish. I'm still driving.
Well, you can play on the YouTube channel the first conference.
Yeah, I got it. Thank you. I'll find something to do. No worries.
All right. Okay, guys. All right. Thank you.
All right. Great job.
Thanks, everybody.
Thanks, everybody. Good night. Thank you.
Bye-bye. Good night.
All right, thank you.